Thank you, sir. So now for our final session, we have Mr. Pijush Sinha, sir, who is a senior consultant optometrist with vast clinical experience. He will be presenting on Pentacam and its role in anterior segment analysis, which is crucial for cornea and refractive evaluations. Over to you, sir. Welcome, sir, to the session.
So my screen is visible to you, right?
Yes, sir, it is visible.
Yeah. So you can see the screen, right?
Yes, sir.
Okay. So before starting the presentation, I would like to appreciate the last two presentations by Sanjay sir and our respected Rajkumar sir. It was very well structured presentation, and it's a pleasure for me to present with them also. Hello, Rajkumar sir. You are well.
So, how are you, Pijush?
So yeah, very nice, sir.
Okay.
Yeah. So so let's start with the clinical scenario. So suppose a patient is sitting in front of you and you are doing the refraction and you found that the patient refraction is actually not matching with the patient vision and it is not explaining the vision properly. So here you need to look beyond numbers. You need to analyze the cornea in a proper way, right? So here is the role of Pentacam. So we finished the retina visual field, B scan. Now let's start with the cornea. So my name is Pijush Kanti, and I'm an optometrist, and I love to interpret Pentacam report. Let's start. So yeah. So in the beginning, by looking at this topography map or geographical map, most of you get confused that why I'm starting the geography lecture instead of Pentacam. So it is just a way. Let me put the laser pointer first here. Uh, so yeah, so you can see here many areas are in warm color and some areas are in cooler color. So this is the same principle or same way Pentacam actually explain the cornea. Here, the reference body, whenever we are measuring something like you are measuring the height of the Mount Everest, so the reference is sea level. From the sea level, the height of the Everest is measured like 8,000 meter. So here, Everest is very high, then sea level. So it is appear in a red background. But the more the depressed area, it is appear in a cooler color and elevation point appear in a warm color. Similar concept applied in Pentacam also. This is the machine that we use. This is the Oculus Pentacam to scan the cornea. It is based on the Schimflug principle, which states that the image plane, object plane, and the lens plane is tilted in such a way that they intersect at a point so that they can scan the cornea properly, because the cornea is not a plane surface. It is a curved surface, right? It is an aspheric. In the center it is steeper, in the periphery it is flatter, right? So we can say it is a prolate cornea. So to scan the cornea, if the image plane, object plane, lens plane are parallel and they are in a plane surface, they will not be able to capture all the corneal points. So this is why they are tilted. So they can scan the whole cornea within 2 seconds only, and there is near about 138,000 elevation point are scanned in the cornea, where they are scanning the front surface of the cornea, back surface of the cornea, pachymetry, and also we can scan the anterior chamber, angle, everything here by using the Pentacam. So indication, why we do Pentacam? What is the need? First of all, detection of keratoconus kind of condition. Suppose you are doing the refraction and you found that patient is having a first time cylindrical number he is getting, like that is more than 1.5. It's definitely you should prefer to go for the Pentacam for the patient. And also you are doing the refraction, found scissoring reflex, then Pentacam is a good tool to diagnose any kind of anomaly. Patient came for refractive surgery. It can be LASIK, PRK, Contura, or SMILE, anything. You can go for Pentacam first to know the corneal structure properly. And diagnosis of any corneal ectasia, it can be keratoconus, keratoglobus, PMD, or degenerative condition like pterygium marginal degeneration. Pentacam is a very powerful tool. Contact lens fitting like RGP, orthoscleral, to know the location of the cone, Pentacam plays the role. And also nowadays, to know the light scattering, amount of how much light is scattered in the cornea, to know the optical clarity. Like many patients, you found that having a very faint corneal scar, and they say, even after I can read the 6 by 6, but the line is not clear. Here in the Pentacam, there is an introduction of a densitometry. that scatter, how much light is scattering. So you can do the densitometry to know the optical clarity of the cornea, something like that. Also here, scanning of the anterior chamber depth and also angles. Nowadays, whenever I get a patient with shallow anterior chamber, I all do Shimplug images. I see them so that I can see the angle also properly. And post-LASIK evaluation. This is how Pentacam report look like. So we are optometrists. We are not engineers that we will learn how Pentacam machine built and we have just a report and we did the report test and the report is in our hand. Now we are going to interpret it. So today I'm going to show you how to do structurally interpret the report and get those significant findings from it. Let's start. So here, this is the first thing that you need to look at is the quality specification, means how nicely. Am I audible to you? Yeah. Am I audible?
Yes, sir, you are audible.
Yeah. So quality specification tells that how nicely you captured the test. This value should be in between 0 to more than -1. In case of corneal ectasia, it is showing the hyperprolate condition. But whenever patient come to us for a LASIK, we make the prolate cornea to oblique, means we are making the center of the cornea flatter, periphery steeper, something. So it is, if it is in plus sign, it is showing oblate cornea. If it is in minus sign, it is showing the prolate cornea. It should not be go beyond -1. Another, you need to see the astigmatism value. Like say if the astigmatism, you need to compare the difference of astigmatism between two eye. If it is more than 1.5, it is not a good sign. Another values like here, this is the steep radius of curvature. This is flatter radius of curvature and the dioptrical value of them. Here, this is the R mean. That is the smallest radius of curvature of the cornea. This should be more than 7. And here, this is the radius of curvature periphery. Their difference should not be more than 0.8. Note down whatever I'm saying. So it will be helpful for you in your clinical practice also. I'm telling to all the students who are listening to me. So similar way, you will compare the back cornea also, and then Chemex value. This Chemex value is very important because it is telling you the highest or steepest keratometry value. It should not be more than 47.20. If it is more than that, it is a suspected case. Then thinnest local, there is three things you see: thinnest local, pachy apex, and pupil center. These three are very important. Pupil center is for refractive surgery kind of condition. Pachy apex tell you that it is the location of the geometrical center of the eye, and the location just above the geometrical center, what is the thickness of the cornea. Thinnest local is the position of the thinnest local. Their difference should not be more than 0.5, okay, mm. So here you see the x-axis and y-axis deviation. Suppose x-axis is like horizontal manner, y-axis is the vertical manner, right? So if the value is in the plus sign and minus sign, it indicates where is the position of the cone. If you see the plus sign in y-axis, it means the position is up. If it is minus sign, position is down. In x-axis, if the position is plus, it means it is temporal side to the nose, and if it is minus, if it is nasal side. So this is how this value should not be more than 0.5. Another, like these values are little, not that much important, but we have to know the values, that whether the value is normal. The corneal volume, the more the cornea is ectatic, the less will be the corneal volume. It should be in the range of 60 plus minus 3, and chamber volume, it should be in between 150 to 200 mm square. So this is the value, but for the ectasia diagnosis, it's not that much important. I told you, yeah. This is the sagittal curvature map. Sagittal curvature represented in a color coding manner. The more steeper, the more warm color, the more flatter, more cooler color. It can appear in multiple various kind of shape. Like, can anyone tell what is the shape of this sagittal curvature front? Yeah,
Symmetrical bow pattern.
anyone? Yeah, it is a symmetrical bow tie pattern. Very nice. So even after the patient is having symmetrical bow tie pattern, if you need to see the keratometry reading of all these things. So here you need to differentiate, make the difference. What is the difference between these two corresponding point of the keratometry reading, like 45 and 45? So their value or difference should not be more than 1.5. If it is that, it is indicating something else. Don't go directly to the diagnosis only by looking at the four refractive map. The elevation front. So here, whenever you are doing Pentacam, remember to put the date of birth of the patient very nicely, because machine is having its normative data, just like the visual field. So here, normative data, and machine is having a best fit sphere based on the patient normative data. And machine compare that best fit sphere that I will show you in the later slide with the value with a corneal elevation point. If the elevation point is more than that, it will appear in a plus sign. If it is less than that, it will appear in a minus sign. I will explain this thing later. Here, another back elevation. Whenever, remember this thing, if the patient you are looking for keratoconus or any corneal ectasia, it start from the posterior and go to the anterior. Okay, so if anterior only shows the yellow and posterior is not green, that means it is not a case of keratoconus kind of condition. Corneal thickness shows you the thickness of the cornea. So here also, even after these all values are normal, the corneal thickness value should be more than 500. The borderline for the Pentacam, it say that the value should be more than 470, but you need to calculate the difference between the corresponding point of the central 5 mm area. It should be more than 30 micrometer. This is the 12 and 11 point. This map is from Bellin-Ambrosio enhanced ectasia. So here you see that this is the 12, 11 point and 12 point. So here in 12 point, you see the progression index average value. This value should be more than 1.20. And here in these are the CTSP and PTI lines. CTSP and PTI tells you the change of the corneal thickness from center to periphery. As you know, from center to periphery, cornea get thicker in thicker. So here it should be continuous up to 6. If it is deviating before 6, it is abnormal. This is the normal line. This is the upper standard deviation, and this is the lower limit of standard deviation. This is the percentage thickness index. This one is more sensitive than this one. Okay, and this all the values should be appear in a white background. That is normal. This is the best fit sphere that I was telling to you. You see the machine is having, this one is the BFS. Red in, if so you see, just compare this red with this one. Red is below the BFS, so it is in cooler color. Blue is above, so it is in warm color. This is how it is done. This is the tongue projection shape, and this one is the isolated island. These two mainly found in corneal ectasia keratoconus kind of condition. This is the normal value where you see the QS value is okay, KMX value, what I told you, these are the summary of it. You can take the screenshot of it also. KMX value, what should be the limit. These are the shape of the sagittal curvature front, right? So here it can appear in a round, oval, superior steepening, inferior steepening, symmetrical bow tie pattern with skewed radial axis, asymmetrical bow tie pattern with inferior steepening, asymmetrical bow tie pattern with superior steepening, asymmetrical bow tie pattern, inferior steepening with skewed radial axis, butterfly clap flow, and vertical T. So here also you need to look at the, if there is a skewness, measure the degree of the skewness. If it is more than 22, that means it is abnormal. This is how, this is the sagittal front symmetrical bow tie pattern. This is the elevation front. In the elevation front, you need to look at, this is the thinnest local point. This is the circle one. The corresponding point of the thinnest local should not be more than 12. Remember this thing, just take a note of it. This is the elevation back. Back elevation, the thinnest, the corresponding point of the thinnest local should not be more than 18. Remember this thing also. This is the Pecky tree map. This is the Bellin-Ambrosio enhanced ectasia. So it is enhanced BFS. It is working on it. So this is the comparison. This is the standard BFS and this is the enhanced BFS. Why this enhanced BFS came to play its role? Because in standard elevation, there is, if there is a subtle change in the center of the cornea, subtle steepening, this standard BFS will not be able to catch that one. So this is why what machine does, machine exclude the central 3.5 mm area from the center of the cornea, so that if even after there is a slight elevation point, machine can detect it properly. And this happen. So here, this is the front and back elevation map from 4 refractive map. After excluding the 3.5 mm area, 3.3 mm area, this is done by the machine itself. If machine suspect that there is a steepenism, then machine take 3.0 mm and exclude it. And if it is this is one is the enhanced one. You see in the front elevation there is yellow, but in the back there is green. So it indicates that it is not a case of keratoconus. It can be, this one can be due to tear film disturbance or corneal contact lens warpage or any kind of surface abnormality, but not because of ectasia. Another thing like progression index should be less than 1.20. CTSP, PTI both line continuous up to 6. Here, these are suspected. I will go in detailed analysis of every report properly. Here, deviation front back, the deviation of progression thickness, these values should be less than 1.6. Then only it will appear in a white background. If it is in between like 1.6 to 2.6, it will be in yellow background. If it is more than 2.6, it will be in red background. So this value should be less than 1.6. This is 1.47. It is in white background. That's okay. This is the classification that we follow every time to grade the keratoconus or corneal ectasia. Stage 1 kind of keratoconus, if you get the patient astigmatism less than 5 diopter with KMX value is less than 48, that is stage 1. In this stage, you can give glasses to the patient and he will be happy with that one also. In stage 2, the cylindrical number will go higher, 5 to 8, and KMX value less than 53, more than 48. Corneal thickness more than 400 but less than 470. This is stage 2. Even after in this stage also, you can give the glasses, but the contact lens play always the superiority, but glasses can also be a management option for this patient in this stage. But in stage 3, glasses will not work now. Here, the cylindrical number will be more than 5, but here it can be more than 10 also in stage 3, where the K value is more than 53 but less than 55, and corneal thickness 300 to 400. Here, contact lens, the only option here for the optical clarity and optical correction I'm telling about. And in stage 4, you see if the value is more than 55, definitely it is the stage 4 kind of keratoconus. This is the first case. So what I'm actually planning is like I will interpret one case properly and I will hand over other cases to the audience so that it will be more interactive, right? So let's start. So here QS value, okay, Q value is also within normal range, less than 1, very nice. R mean and R periphery both are with the normal range, and this here, this value should not be less than 6. It is also normal. KMX value less than 47.20, normal. Thinnest local point more than 500, normal. Their difference less than 0.5, normal. If you see here, slight superior steepening, but maximum values are within the normal range, that is acceptable. These two value, front and back elevation, should be identical to each other. But even after here, they are not identical. But here you see the corresponding point of the thinnest local in broad front and back elevation. They are here less than 12, less than 18, that is normal. And here maximum values are within normal range. So it is looking like a normal cornea. This is the Bellin-Ambrosio map. Here, after excluding the 3.5 mm area, even after that, there is no yellow or red zone. That is a good sign. And progression index less than 1.20. And here CTSP, PTI both line up to continuous up to 6. And all the values, deviation, front, back, progression, thickness are in white background. So it is a normal cornea and there is no corneal ectasia kind of condition. Let's go to the other case. Now, anyone of the audience, just try to interpret it. It will be fun. If you have any done any mistake, no issues with it. We are just here to learn, right? Anyone? Hello, am I audible to you?
Yes, sir, you are.
So anyone from the audience? No?
Okay, let me try.
Yeah.
So first, our QS is okay. So we can move on to the K readings. The K readings, if we check the color there, it shows some steepening superior. It's giving like
No, first of
if
all, you need to tell these values first. Are they normal? Then go to this one. Okay, don't go directly to this one. It will be confusing.
okay.
First, QS
The
value.
QS value is okay, and Q
This one.
value is within -0 to -1.
Yeah.
Yes.
Then
So
this one.
yeah. Which one? Which one?
The KMX value.
Okay, the K max values. So we said it should be the top should be within 500.
So the KMX value should be less than 47.20. Thinnest local, it is more than 500. Okay.
Yes.
And here you also you see in the superior sagittal front, yes, it is asymmetrical body pattern with superior steepening, but the values, if you do the difference, it is
The
less than
difference
1.5, corresponding point
1.5.
of the central 5 mm area. That is
Yes.
front, it is less than the corresponding point of the thinnest local is less than 12, and here corresponding point of the thinnest local, it is less than 18. That is normal, and here maximum values are also normal. Their difference, if you calculate the difference 564 and 611, even after it is more than 30, but then also they are in the normal range, so we might consider it is a normal cornea. Just one value is abnormal, it doesn't mean that cornea is abnormal. Here in the Berlin-Ambrosio map, you see after excluding the central 3.5 mm area, there is no yellow or red zone. That is acceptable. Average value is less than 1.20, normal. With the CTSP, PTI, both line are continuous up to 6, and all the values are in the white background. That is normal. So it is a normal cornea. But here, here the confusion comes. So in this specific cornea, you see that here the QS value, just I'm showing you lot of reports on this so that you can understand properly and differentiate how to differentiate from a keratoconic eye. So here you see the QS value is okay, Q value normal. You see the KMX value, it is more than 47.20, and the Peki apex and thinnest local, they are less than 500, even less than 470. So by looking at all these values, in the beginning, you might consider, okay, it can be a corneal ectasia. Here also we see maximum values are more than 47.20. That is abnormal. But in the front elevation map, you see the corresponding point of the thinnest local. It is less than 12 and it is less than 18. That is normal. Even after that, the thinning is there. So for refractive map, overall saying it can be a corneal ectasia, but if you go to the Berlin-Ambrosio map, you see after excluding the central 3.5 mm area, there is yellow zone, but posterior there is green zone. What I told you in the beginning, that if the posterior surface having the green, that means it is not a case of keratoconus. It might be possible that patient is having a steep cornea already with a thin cornea, but it is not a case of corneal ectasia because the progression index 1.20 and CTSP PTI both line are continuous up to 6. So just these two variables are in yellow background doesn't establish it is a case of corneal ectasia. So always correlate one value with other value. The clinical correlation is also very important. Only looking at the Pentacam report and you are diagnosing it is a case of keratoconus, it should not be like that, because you know the keratoconus having the 7 clinical signs in slit lamp and normal also, like monsoon sign, Rizuti sign, prominent nerve ending, oil droplet sign, right? Acute hydrops. All these need to be checked properly. This one also looking the same, like all the values beginning are within the normal, but here you see this is less than 6 and this one is more than 47.20. That is abnormal. 49 is a very steep cornea. Definitely, I agree with this one. And here this is 470, absolutely abnormal. But here you see overall corneal steepening. But here no values are there which shows abnormality. It is less than 12, less than 18, and the overall corneal thinning is there. But if you look at the Bellin-Ambrosio map, there is total green. That means it is not a case of keratoconus. It is mean that the patient already having a steep cornea and thin cornea, but it is not a case of that. Even after that, just tell the patient to come for a follow-up visit in every 4 months or 6 months, so that we can see the progression. Even if there is any progression, we can track that one and manage accordingly. Here, now this one is special one. Can anyone interpret this one? I already interpreted 3 or 4 maps, so you might get the idea how to interpret. Now any one of you have to interpret full from starting to end, and need to give the diagnosis. Yeah. Please go ahead.
So the QS value is okay. Q value is more than -1. And the Kmax value, it is more than 47.2 in this case. And the corneal volume also, it is also affected.
The thinness local, is it normal?
No, sir. It should be more than 500 microns. Here it is less. It is 364.
Yeah. And you see the y-axis deviation is more than 0.5, right? So it is also abnormal.
Yes, sir.
And then go to this maps. First of all, tell me which shape it is.
There is inferior steepening there.
Yeah, it is inferior steepening. Now, whether it is normal or abnormal.
This is abnormal. It is abnormal.
How?
There are what colors? The red. There's red color at the center, and if we check corresponding values, the difference is greater than 1.5.
Yeah, that is 1.5. Yeah. Then
So,
go to this one.
That is posterior. That's front elevation. There is.
It is also abnormal, sir, because it should be less than 12.
It is also
it should be less than 12. Yes.
And that one is also because it should be less than 18.
Yeah, fine. So can you tell me the shape of what is the shape? So here it is actually an OL glass pattern. It is going to be a tongue projection, because this will be missing after few days if it is an progressive kind of condition. Here you see the corneal thickness. If you calculate the difference between these values, it is more than 30 micron, and here in the centrally it is very thin cornea. And so here this is the Bellin-Ambrosio map, which tell in detail about the cornea. Now interpret this one. Hello. Am I audible?
Yes, yeah, now audible.
So only you are telling, but I see there is more than 80 participants are there. So what about others? Why you are not taking participation in the discussion? Okay, you should not be afraid of making mistakes. Even I make mistake. It doesn't mean that I know everything. No one knows everything. So we should take the participation so that we can understand properly. So yeah, it is quite looking difficult, but if you look in a simple way, this is the front and back elevation from the refractive map. After excluding 3.5 mm or 3 mm area, it is more enhanced manner. And you see these all values are, these two map are appear in a red background. What I told you, this value, minimum progression index, average value, it should be less than 1.20. That is more than that one. and you see it is starting from 300 CTSP and going to the peripheral is getting thicker, but the starting point itself is abnormal. And the PTI, the percentage, how much percentage there is change of the corneal thickness, it is deviating before 6 mm. That indicate that there is a rapid change of the corneal thickness from center to periphery. All the values are more than 2.6 and overall it is more than 2.6. That is a case of nipple cone keratoconus. This is also the same thing. It is also a case of nipple cone keratoconus. And here you also see the Kmax value is 65. Now tell me, what is the stage of this keratoconus?
Is severe case.
Which stage? There is stage 1, 2, 3, 4. I showed you in Amsler
Oh,
Chromage classification
is
system.
is three. Is 3 or 4?
No, it is 4, stage 4. It is not 3. If
Yes.
the stage 4 means the Kmax value, it is more than 55. Okay. So it is a stage 4 kind of keratoconus. Here, this value should be in white background, QS value. But yeah, the patient was not able to fixate properly that time when I was doing. So it was in a fixation, but it is showing a hyperpolarized cornea. You see, what I told you, this value should be more than 6, but it is 3.5, and their difference is more than 8. That is abnormal. Kmax value is more, thinnest local is this one. So now suppose you did this scan today, patient, and you call the patient after 3 months. Patient came and you found that the thickness of the cornea reduced 30 micron. Then today's or the date. So it means there is a progressive keratoconus. So like even after you go for the optical correction with contact lenses, first, if it is a progressive kind of keratoconus, it is better to go for the collagen cross-linking and then go for the optical correction. Collagen cross-linking will make the cornea stable, and after giving the optical correction with contact lens, it can be rose-K contact lens or scleral contact lens, it will be a good option. If you see the Bellin-Ambrosio map, you see these are all in gray, red background, and this is more than 1.20, and PTI is deviating before 6, and all the values are red background. That is abnormal. So we saw a lot of keratoconus. Now it is separate one. It is another disorder. So here you see QS value showing little data gap because the patient was not able to fixation difficulty. Q value is also within the normal range. You see the Kmax value is high, but there is a typical pattern you see here in the sagittal curvature map, that there is asymmetrical bow type superior steepening, and the steepness is going upward sign. Okay. And here you see elevation front and back are nearly looking normal. Like here you see the corresponding point of the thinnest local is 13, 10. Even after this one, the thinnest local shifted upside. Okay, and upside you see there is flattening, and that's why it is in cooler color, and here also flattening. So superior flattening, and here is the steepening. There is a sign of against the rule astigmatism. Also the steepen. So here the thinnest local is shifted up, right? So it is degeneration. It is not the picture of the patient of the scan. It is I collected it from internet. Sorry for that one. But here you see terine marginal degeneration is a corneal degeneration. It is not a corneal ectasia. It starts from superior, where in slit lamp you will see progressive thinning, vascularization like Panus type with lipid deposition, and it will go to the periphery only. It will not reach to the central one. In severe cases, the central cornea might get affected. So it is a case of terine marginal degeneration. So here Bellin-Ambrosio map will not work because it is made to detect the corneal ectasia, not a degeneration. So this is why it is showing in green background. It doesn't mean it is a normal cornea. So here you see this red line, it is deviating up. It is not down because it is in superiorly the cornea is getting thinner. So it is going up. So this superior steepening you will see in terine marginal corneal degeneration. Now, can anyone tell me what is the shape of this cornea? Anyone?
Crab claw pattern.
Crab claw pattern. It is seen in which case? Try.
It's a corneoectasia.
Yeah, it is a type of corneal ectasia, but specific, you need to name the case.
PMD.
Yeah, it's very nice. Can you tell your name, please?
Junaid.
Yeah. So yeah, you are right, Vinodji. It is a case of PMD. So here QS value, okay, Q value is also within the normal range, but you see here the KMX value is 52 and thinness local is less. This is 457. This is classical kissing dove pattern. And here you calculate the difference between these two corresponding point of central 5 mm area. This is 42, 47 more than 1.50. Here you see the corresponding point of the thinnest local. It is more than 12, it is 21, and it is more than 18, this is 38. That is abnormal. You see here, if you will do the difference calculation, 521, 486, that is abnormal. 509, 477, more than 30, that is abnormal. So this is the case of pellucid marginal corneal degeneration. This is how the Belen embryo look like. So here also you see the back elevation shows yellow, but front elevation shows green. Why? Because pellucid marginal degeneration affecting the inferior from 4 to 8 o'clock area, but it is not starting from posterior like keratoconus. Here average is less than 1.20. CTSP, PTI both line are continuous up to 6 because the central part is remain normal and it is happening inferior side. So if you see the inferior steepening with kissing dove pattern clap glow, it is a case of PMD. If you see the superior steepening with peripheral pannus type vascularization with lipid deposition, it will be a case of pterine marginal degeneration. And if you see the central cone type thing that I showed you in a lot of keratoconus cases, it will be a case of keratoconus. And overall steepening severe, it can be a case of keratoglobus. Here you see it is a case of keratoconus by looking at this one, inferior steepening. QS value, okay, Q value is also within the normal range, but you see the KMX value more than 47.20, even after the central is 521. But if you see here, there is overall corneal steepening is there, 44 and 53. There is difference between these two corresponding point that is abnormal. You see here it is more than 12, here it is more than 18, that is abnormal. And all the values here like 615, 542, more than 30 micrometer in the corneal thickness, that is abnormal. This is the kind of keratoconus. You see in the back elevation front, both are red with here average 1.89, and here this is deviating before 6. This one is also, so it is a classical keratoconus case. And now whoever told till now, don't say now again. And I want new participant in the discussion, because I'm not here to give you the lecture. I'm here to discuss with you so that the learning will get more perfect, right? Let's start. So other new participants. Yeah.
The QS value it's okay, and the QO value is less than 1. The R minimum it's less than 6. Here the dentist location it's more than 500, and the K max is 84, 48. It's maybe it's abnormal. Yeah.
But only looking at one value, you cannot comment. You need to tell all the values here.
Okay. Here for the sagittal curvature, it's 46, and the elevation is 2, so it's not reached 12. So it's less than 12, and the back it's less than 18. So here it's okay.
What about this one?
Here 500. Also it's okay, but it's comes green color. Here the difference in front and back it's come in green color, so it's okay also. The minimum value it's less than 1, so it's okay.
This value should be less than 1.20. And what about these two lines?
Here, this point I'm not understand it when you explain
So
it.
here, this is the corneal thickness special profile, and this is the percentage thickness special profile. This
Okay.
graph tell you the change of the corneal thickness from center to periphery. If you see rapid change here from center to periphery, as you know, centrally the corneal thickness should be about 500 to 550. In different book, it can somewhere it can be written as 520, 540, 550. So it should be more than 500. It should be continuous up to this line, up to 6 mm diameter. If the line get deviate before this 6, that is abnormal. And the percentage thickness index, it tell you that how rapidly, what is the percentage of change of the corneal thickness from center to periphery. So it is also continuous up to 6. That is normal. You see here,
Yeah.
all the values are in the white background. Just
Yes.
deviation of progression is more than 1.6. So it is yellow, but overall it is a normal cornea. There is no corneal ectasia.
So it's
And
normal.
this one, new one, new participant. I want new participant. All the participants have to interpret, because we are here to learn, right? Anyone?
This one QS is data not okay. The Q value is more than -1.
So it is a hyperprolate cornea. Okay.
And astigmatism also 7.7. And thinnest local is 434. It's normal is 500.
Fast. What about the Chemex value?
Chemex is also increased from 47.2. It's 67.
Yeah. So overall, this value shows that cornea is not normal. What about this one? What is the shape of this cornea?
It's cerebral degeneration, central degeneration.
I'm the shape. It is a symmetrical bow tie pattern, small manner. But if you see the difference between these two corresponding point, these two, they are more than 1.5. That is abnormal. Here it is an oval glass pattern. It is a tongue projection. Tongue projection always tell that asymmetry in the cone. And if you see only an isolated kind of island, it tell that localized cone. So here in the front there is less, and in the back there is already started corneal ectasia more than 18, and these values are abnormal. If you see here, red background, this is more than 1.20. This is getting deviate before 6, and here it is also getting deviate before 6. All the line values are in red background. That is abnormal. There is also a nipple cone type of so it is a central keratoconus. You see, it is a central steepening is there. Data gap shows, because the patient was not able to fixate properly, it is more than 1. And this is 82. That was very high actually. It's supposed to be like more than 55, but 82 is very high, very severe kind of keratoconus. You see, it is the uh, 282. If the thickness is less than 200, there is no point of going for the collagen cross-linking, and the option remain is very less. Even after, in many patients I have seen with scleral contact lens, the vision get improved. But in this kind of patient, corneal transplantation can be a good option. That is optical penetrating keratoplasty. And here you see these two are showing isolated island. So what I told you, isolated island, tell you the localized cone. Okay. And here also in corneal thickness, very much thin. It is 4 to 97. That is very thin actually. Here in the red background, getting deviate before 6, both line more than 1.2. All the values are in red background. Absolutely, it is a case of corneal ectasia keratoconus. Here it is a you see here, this is 45, a normal kind of cornea. QS value, everything are within the normal range. This is little less, but here difference is also not more than 1.5. It is tongue projection and it is an OL class pattern with corneal thickness within the normal range. But oh yeah, so this patient came, this was actually a myopic patient, came to us for myopic correction. He didn't want to wear the glasses. So here we tried orthokeratology lenses to this patient. I showed this so that you can understand how an ortho-K lens will look like on topography, sorry, in Pentacam and topography also. You see, after orthokeratology, this is the bullseye pattern. You see, in on orthokeratology, we change or alter the shape of the cornea. We make the corneal center flat, mid-peripheral steepening, and periphery again goes to the normal one. So there is redistribution of the epithelial cell in this mid-peripheral area. So it get steeper. So this is the typical bullseye pattern kind of thing that you will get in post-orthokeratology lens fit. So patient will use this lens overnight and come to the next day follow-up, and we will do the topography. And here he will be glasses free. Post orthokeratology. Can anyone guess? Let's stop. Guess what can be happen in this patient. What was the procedure that was done, and what is the shape of the cornea? You have two options: prolate cornea or oblate cornea. Yeah, anyone? Just guess.
Oblate.
Oblate. Can you define what is oblate shape?
Because Q value is n plus 1.54.
Yeah, perfect. That is the perfect answer, because the Q value is plus sign. Oblate means central, it is flat. Periphery, it will get normalized or little steeper. So this case is a case of post LASIK patient. Okay. So here in LASIK patient, we make the cornea flatter so that where in the myopia, the light rays are getting focused in front of the retina. But when the corneal curvature got flatter, light rays will now focus on the retina. So QS value is okay, and here you see Chemex value. So in the keratometry or pentacam, remember the corneal curvature should not be less than 35 or should not be more than 47 in pentacam, but generally it should not be more than 45 also. Here overall thinning is there, but cornea looks stable. This is the Berlin-Ambrosio map. So the most confusing part that will happen to both maximum students participating here, that why there is a red circle if the cornea is normal, right? So in LASIK patient, we are making the cornea artificially flat. So when the best fit elevation or best fit sphere is applied to that cornea, then the peripheral part of the cornea remains steeper and central is flatter. So this is the false positive error that happened in Pentacam. So you should not get worried about it. It's a very normal condition. Even after you see here that it is getting delayed before 6, but need to have a close follow-up that whether the number or values change over the time, so that we can track the changes on the cornea. Thank you so much.
Thank you so much, Say. I have a question about orthokeratology.
Yeah, you can.
Which values give us, let's say, makes patient they cannot qualify for orthokeratology since it displaces the corneal cells? So which values on Pentacam should we say this is the minimum for us to use orthokeratology as a control, in my opinion?
Okay, so if someone is having myopia and come to us for orthokeratology, we do the scanning to know the corneal parameter. But if you are measuring it and found that the values are exceeding 47 and there is an ectatic condition, definitely orthokeratology will not be the option for that patient. And we need to go for the ectasia management. The values should be within the normal range, less than 47, and thickness, it should be normal, and there should not be very much corneal thinning. And the corneal, the overall parameter should be normal. It's not like there is a specific fixed time, but there should not be any ectasia, so that we can go for the orthokeratology.
Sir, I have answer question.
Okay, yeah, everyone can type your questions in the chat box. So there is one question from Leon Sweeney. Sir, can you summarize the Berlin-Ambrosi map again?
So Berlin-Ambrosio enhanced ectasia is little different than the normal BFS that is applied. So let me put the slide. So here you see this one is the standard BFS. Okay, you see there is an overall spherical dome shaped kind of reference body that is thought to compare the elevation point of the cornea. So if the corneal point is more than or elevation point like in this manner here is that, then it will appear in a plus sign. If it is below, it will appear in a minus sign. But in case of early keratoconus changes or corneal changes, or like there is a specific kind like FFKC or early keratoconus changes, then if there is a subtle change or minimal changes to the elevation point, as it is applying a generalized dome shape reference body, it will not be able to catch those subtle changes. So this is why Berlin-Ambrosio map is introduced, where what machine does, it actually excludes the central 3.5 mm area. So even after, suppose this is the elevation point, but if I exclude this area, then this elevation point will appear more enhanced manner. So I'm enhancing that elevation point so that I can track those subtle changes. So this is where Berlin-Ambrosio enhanced ectasia is working. Nowadays, there is an additional refractive map that is included in the Pentacam. Previously, we did 4 refractive map with Berlin. That's it. Nowadays, corneal ABCD grading is also come to play its role. So where keratoconus grading with ABCD, where A indicate elevation, the anterior corneal curvature, B indicate posterior corneal curvature, C is the CCT, and D is the visual acuity. So the ABCD grading is also in a very working manner in many institutions to grade the keratoconus. But even after that, yeah, the importance of this Berlin-Ambrosio map are very powerful. Yeah. Thank
Okay,
you.
sir, there is one more question from Junaid Afridi. Which parameters considered in refractive surgery laser?
Refractive surgery laser, it depends which type of refractive surgery you are preferring. If you are preferring a thin cornea, then like PRK type of procedures that usually nowadays no one does PRK. Everyone is going for the bladeless kind of LASIK. But if you are going for the PRK, even after the corneal thickness is 470 or 480, you can go for that one because it is done without any kind of epithelial ablation. But in case of LASIK kind of condition, the corneal thickness should be more than 500 to have that residual stromal bed. Nowadays, the most used is Smile Pro, where a small lenticule is extracted from the cornea itself. So even after the cornea is like 480, then also it can be done performed properly.
Okay, sir. There is one more question from Junaid Afridi. In axial map, how we find difference between corresponding values?
In axial map, can you repeat? Like in this
Yes,
map.
sir. In axial map, how we find difference between corresponding values?
So here in this sagittal curvature front map, you see this is the central 5 mm area. So here you need to calculate the difference between this value and this value. These two are corresponding point to each other. These two values are corresponding to each other. These two values are corresponding to each other. So if you do the calculation of these two, 43.9 and 43.2, their difference is less than 1.2. That means there is no that much significant difference in corneal keratometry reading from superior to inferior. That's where it give a gross assessment that okay, there is no such kind of corneal ectasia changes.
Okay,
Okay,
sir.
sir.
And correspondence superior and inferior.
Opposite point.
In this,
Opposite point.
okay, okay, sir. Okay, sir.
Okay, sir. There is another question from Ajay Singh. Is tear film instability affect the accuracy of pentacam measurements?
Yeah, very much sure. Because many of the time, what happened that what I showed you, some cases where yeah, here you see in this Berlin map, you see here there is a yellow and there is green. So every time, what we should prefer that if you are performing pentacam to any patient, take 3 reading consecutively. If you find any yellow spot or reading, do prefer to take it again. Many of the time it happened to me also that in the first, even after the quality specification is okay, if it is in yellow, I repeat again, and by applying after putting a lubricating eye drop and surface gets stable, or take them, tell the patient to blink several times and then repeat, and this yellow zone actually goes off. So it happened. Definitely there is a role of tear film.
Okay, sir. There is another question from Munesh. Do we notice pattern changes like in LASIK if patient had corneal cross-linking?
Okay, collagen cross-linking, the main aim is to make the cornea stable, stronger, right? If you found the keratometry reading values are changes, like in the first visit, the keratometry reading is 49. In the second, after 6 months, it became 50. There is a progression. So in Pentacam, there is a dedicated comparison map is also there from previous to today. So if there is a progressive thinning with keratometry changes value, then we should prefer a C3R. But C3R will not improve the vision optically. It will stabilize the cornea, but it is also having a little validity, like it will work for 1 year, and then again patient might need to go for a collagen cross-linking. So the values will get stabilized maximum cases, but in many patients, I have seen that even after C3R, it get in a progressive stages. Like we have to focus on the KMX value and thinness local specific.
Thank you, sir. So I am audible to all the speakers of today's session. So thank you so much, sir, for the insightful session and informative session. We truly appreciate your valuable time and knowledge. And thank you all the participants for joining us today and being so interactive throughout the session. So, and also I would like to take a moment to acknowledge this leadership behind this initiative session. Our founder Muhammad Adnan sir, co-founder Muhammad Asad sir, and administrator Muhammad Arwan sir. Thank you so much for organizing such a meaningful academic platform.